اوكي
فول سكرين يا فندم.
فول سكرين.
تمام كده. تمام كده.
تمام. جو اهيد.
بسم الله الرحمن الرحيم. السلام عليكم ومساء الفل عليكم جميعا. It's a great honor and great pleasure to be here on this wonderful course that I have shared a little bit in the great efforts of my dear Professor Dr. Ahmed Elsheikh since 13th of June till now. It have been tough months ago, and of course it's a great pleasure to be also with our dear professors, Professor Absalam Eid, and it's a great honor to be the first speaker before him. It's really my deep appreciation for him, and also Professor Muhammad Abdul for his presence here. It's a good day about the femur. Yesterday we have a good focus on the proximal part of the femur. Now we are shifting to the shaft and then shifting to the distal femur. I'm Ahmed Elsheikh, lecturer of orthopedic surgery at Benha University, and now senior clinical fellow of reconstruction at Royal National Orthopaedic Hospital, Stanmore, in UK. My talk about the fracture femur. Fracture femur cannot be covered in one day, so I will be talking about the current controversies. So I may be missing some bits of the whole topic, but just let's take it through the main controversies to find a final say, or what have we got evidence-based to solve these controversies. My objectives today will be two main things. The first part, which is the evaluation of the patient himself, and then the fracture. So evaluation of the patient, this is the first half. Second half, evaluation of the limb, choice of treatment, and then what are the controversies at the moment: timing of surgery, positioning, entry, reaming, dynamization, open or closed reduction, and how to deal with a union or malunion. This first part is really important because we need to save the patient before we can save the limb. The patient is the main target of your treatment. Our colleagues in the ER, in the A&E, our junior colleagues who are the first doctor to treat the patient, you have to be careful when you are dealing with this. You have to focus on this part of the lecture very seriously. Major trauma assessment, initial management. You get a patient with fracture femur. Fracture femur, by definition, in most patients, it's high energy trauma. We still can get some fracture femurs, which is low energy trauma, but most of them road traffic accidents, young, high energy trauma. So you need to follow the ATLS protocol, which is well known: airway, circulation, breathing, exposure, neurological assessment, secondary survey, primary survey, secondary survey. The femur as a fracture should be identified at some point, which is not the point number one. So you should be systematic. In management, first line intravenous morphine. This is very important to give the patient some rest, or ketamine. Non-steroidal will not be effective in doing the pain management. Antibiotics, if the patient had an open fracture, you need to give it this as soon as possible in the first 3 hours, coamoxiclav or cephalosporin. And this will be continuous at the first debridement. Then ultrasound, the EFAS or the extended focus assessment, sonography of trauma, whole CT, whole body CT if it's available. This will save you some time. Intravenous tranexamic acid, which is Cabron, to decrease the inner bleeding or decrease the bleeding from the hematoma. This is very important to be given only in the first 3 hours. After this, it may be harmful. So you should ask the nurses to give the patient the tranexamic acid in the first 3 hours. One more thing regarding the coagulability, ask about anticoagulant. And I'm sure that myself and some of our colleagues may just overlook or forget to ask about this, especially in elderly people. You should ask, is the patient on aspirin, clopidogrel, or any of the heparin or whatever of these anticoagulation, because you need to deal with these things before taking the patient to the theater. So it's very important that you start reversal of these agents from the beginning. Fluid replacement, it's 1 unit of plasma to 1 unit of blood. It's a bit different between the protocols, but this is what we have here in the UK. Interventional radiology in specific situations. Heat loss prevention, it's very important to keep the patient warm. Hypothermia is one of the lethal things to the patient in the ER. So heat loss prevention is a very critical thing. Fracture splintage, here is what we all know how to do, doing the slab or stoma extraction or whatever to give the fracture splint, decrease the hematoma, decrease the pain, and protect the skin, protect the vasculature. And then you should decide if the patient is eligible for damage control or definitive surgery. This point is a bit controversial, and we will just shed more light about after a few minutes. But generally speaking, if you get the patient in the ER and you do the resuscitation, and then you ask about is that resuscitation is adequate or not, simply look at the urine output, look at the lactate. Lactate should be normally less than 2.5 millimole. This is the most sensitive indicator. Again, it's a bit overlooked. Not many of our colleagues know about this and request them. Please request serum lactate after you have stabilized the patient to see if what you have done is sufficient or not. Gastric mucosal pH, if available, go for it. Basic deficit, again, it's something very easy. You can request it from the venous blood. You don't have to do arterial blood gas. You just do venous blood gas, and then you get the basic deficit. And as orthopedic surgeons, which we are not so clever in reading the blood gases, so my dear colleague, just one number that you need to look for, base deficit, and it's simply written in numbers. So you got between -2 to +2. This is a normal range. Before and after are abnormal. So simply look at base deficit. So urine output, serum lactate, base deficit are very simple things to assess your resuscitation for polytraumatized patient. And then again, I'm making things very simple. What if we decide to take this patient to the theater to fix his femur because this patient has nothing else? He is just isolated fracture femur. Can we do this in 12 to 24 hours? So you should look at these things. Systolic blood pressure. Is it okay or not? Does he need catecholamines? Does he have urine output? Signs of increased intracerebral pressure, hypothermia, thrombocytopenia, thoracic trauma, lactate level more than 2.5. If you got any of these, so this patient will not be able to withstand a long operation. So this patient needed to be treated with damage control orthopedics at the beginning. So you should look carefully at these things. There are more other complicated things, but I just picked the small and easy, straightforward characters that you can look at. If you get an open fracture, don't irrigate in the emergency room. Just remove the cross-contamination, photographic identification, very, very important. Then saline soak dressing, and then prepare for debridement in the operation room. And this will be usually the next day morning list, unless there are gross contamination, compartment syndrome, vascular injury, or multiple injury that you need to put him asleep anyway. Debridement should be done jointly. Social wash, sterile tourniquet the first, wound extension through the fasciotomy lines, three-dimensional debridement. You debride the dermis, the bone, tuck test for any attached bony segment or bony pieces that you are not sure if they are available or not, viable or not. Articular fragment, be very careful. We don't throw away articular fragments easily. High pressure lavage, and then you classify your fracture. Again, this is a very, very critical point. Gastrolithic classification made after the index debridement. It's not an emergency room classification. Compartment syndrome, just a red flag, evolving event. It's a clinical diagnosis mainly. You can still measure the compartment pressure, but again, there are some doubts about it. Is it accurate in all situations? Again, this is something need to be discussed. But if you get it, the difference greater than 30 millimeter mercury between the compartment pressure and the diastolic blood pressure means that you need fasciotomy. But mostly it's a clinical diagnosis, and mostly it's pain out of proportionate of the current situation and pain without stretch. Don't wait till the patient become pulseless, because this is very late. Vascular injury, surgical emergency need to be restored in 3 to 4 hours. Capillary fill is not enough. Preoperative angiography is waste of time. Do prophylactic fasciotomy. Amputation, complex situation that you need 2 consultants to discuss about it. I will not go through this. These are my references for further reading about the basics of how to deal with a patient with high energy trauma like femoral fractures. Then we come to our beloved part, the bone. Let's fix the bone and look at the femur. I'm not going through the mechanism of injury, which can be easily read in where. They are clear enough, classification ortho, we got many classifications that are valid, but I'm talking about the intervention. How can we treat the fracture femur? And specifically, what are the things that you may find it different between surgeons? The first one, when should I fix the fracture femur? Time of intervention. This is very important. Let's come to this review. It's a very good review from 2014. And it picked up most of the controversies that I have discussed today. And in this review, they analyzed about 1,000 patients from 7 trials, and they got a very, very interesting outcome. So let's come back about 30 years back in time, or 40 years. In 70s and 80s, the surgeons were keen to do what's called early total care. So the patient had a fracture, so do this fracture within 24 hours. And what is the cause for this? What are the causes? Because this is reducing the pulmonary complication, incidence of multiple organ failure, reduced mortality, less hospital stay, and then the patient can be out for rehabilitation in shorter time. But with time, 90s, they said, we saw some complications with early total care. There are some pulmonary injury, there is other respiratory distress syndrome, and there may be increased incidence of death. So we don't have to do early total care, and we will do damage control orthopedics to bypass the second hit phenomena, which is between the second and fifth day. So you do damage control orthopedic on the first day, like X-fix for fracture femur, and then give it another 3, 4, 5 days, and then do the definitive fixation. Surprisingly, after a few years, the evidence is having a flip. Damage control orthopedic is not that good, and early total care is not that bad. We got till the moment no clear evidence that early total care can increase the complications. But just take care, this is not for all patients. We still get patients with head injury, chest injury. You should consider damage control orthopedics. So to conclude, early total care is a good thing, and we still can plan to do the patient within 24 hours after the accident. Of course, after stabilization, of course, that this is the isolated injury and the patient has nothing else to deal with. A second systematic review, which was a very good one, because it's compared between the early intervention and the late intervention. This is by Ayman and Minyar, and this is very recent in 2018. And they analyzed the results of 15 studies that met the inclusion criteria, the eligibility criteria, and they found what? The intramedullary nailing of the femur early in the first 24 hours has a favorable outcome. So favorable outcome in terms of pulmonary complication, other respiratory syndrome, pneumonia, decubitus ulcer, multi-organ failure, and mortality. But there was no statistically significant difference between early and late in terms of pulmonary embolism. So we still got something not clear from the literature. Pulmonary embolism, is there any link, or does it favor early or late? We don't have answer. Some people explain this, that this is because of the traumatic chest injury, and it's not a thing that is related to the timing of the surgery. So again, to conclude from this very good systematic review, that the early total care within the 24 hours has favorable outcome rather than delaying the patient for second, third, fourth, fifth, or after a week, or for 1 or 10 days or whatever. So early is fine. Arriving to the USA, we get this one also in 2017 about the timing of the femoral shaft fracture. And this is the cohort study that analyzed the data from level 1, level 2 trauma centers, and they included 18,000 patients. And these patients were operated in 216 centers. So it's a very, very big study. And again, they compared the cutoff value of 24 hours. Does it make a difference? Is early is better than late? And then they found that delayed fixation has a greater risk of pulmonary embolism and a longer hospital stay. So we got here the answer of the pulmonary embolism from this. So again, all the collective evidence now is going through early fixation. But there is a red flag here. Does it mean in the middle of the night? Let's look at this one. It's from 2018, and this very good prospective study from Switzerland. They analyzed the data over 10 years from 2004 to 2014. And they found what? They found that from about 30,000 patients, about 15% of them operated in the middle of the night. Mortality rates, complications were higher in the middle of the night, more than in the morning. So simply, this is totally understandable, totally logic, that surgeon fatigue, other factors like level of experience, the surgery type, the potential or new events that can arise in the surgery in the middle of the night cannot be solved properly. So simply, you get to do the femoral fracture in the first 24 hours, but please do not do this in the middle of the night. This is against the evidence, and you got more prone to complications. This is the first controversy. Implant choice, it's not a controversy, it's more a straightforward thing, because antegrade intramedullary is a gold standard. Can we go for retrograde nail? I think Professor Absalam will have a spot over this, because it's mostly about the distal femoral fractures. We can do it in shaft fracture if there is ipsilateral femoral neck fracture, floating knee, ipsilateral acetabulum fracture to get some space for the acetabular incision, polytrauma patient, or bilateral or morbid obesity patient that you cannot get enough space at the hip joint. What about Orth plating? Again, Orth is not a first choice. It's a second or third choice in cases of ipsilateral neck fracture that requires screwing, or metaphysio-diaphyseal junction, or narrow medulla, deformed bone, or anything that contraindicate the intramedullary. But if you can do antegrade nail, this is the first choice. X-fix, of course, this is for the damage control, contaminated open fractures, massively comminuted fractures, or with vascular injuries. So it's not a long thing to deal about. Positioning, again, we got this review again, and we have 4 positions possible. Supine position, either with traction or not. This is number 1. Number 2, lateral decubitus, either or with traction or not. Of course, lateral position with traction is a very rare situation, but supine with or without and lateral without are the most common. Let's see what is the situation regarding the evidence, and is there any preference for one or over the other. Supine positioning without traction looks the standard one in case of multiple injured patient, because you need to operate the same leg, you need to operate the ankle, the foot, and also that you don't need to waste much time in doing the traction, or you need to be to have shorter time. Again, you protect the patient from having traction injury, pudendal nerve sometimes injured from the traction, having contralateral compartment syndrome, because the other leg you will be lifted, it will be lifted some way to be out of the lateral view of the C-arm. So without traction would be standard in some situations. What about the lateral view? Simple, because you get the entry very easy, and then the sterile coverage of the leg is easy, and then you got the leg hanging without any restriction, you do whatever. But the main disadvantage that you lack rotatory control. So be careful, because you can get the femur in internal rotation or external rotation that without knowing this, without appreciating this, because the patient is in the lateral position. What about the evidence? This flip a study, comparative study from the USA again, it's 2019. They analyzed data from North America, from Canada, and from Ontario Orthopaedic Association. And they found that most of surgeons prefer supine with fraction table, with fracture table, with traction table, which looks like the standard thing. And then 30% prefer the lateral, and only 12% prefer the lateral with the free leg draft. Canadian showed significant preference toward the supine with fracture table compared to the American. So there are some thing related to the training. This is what I wanted to highlight, that it's about where did you have your training, and who supervised you in your first surgeries, because this stay with you for all your life. So there are some things that come from the training. Also, the academic and higher level trauma centers in the USA were more likely to prefer the slopey lateral view. So again, this is something very strange, that why did they do this? It's simply lateral needs more assistance, and it may need some experience when you do this, because the supine position with the traction table is the standard. So if you got no assistant, you can do the femur supine with traction table. This will save you one assistant. But lateral position, sorry, this will need a couple of assistants to get hold of everything. Again, there were no significant difference on the outcomes of having this. So both are okay. It's about your training, about your first surgeries. Nail entry. Again, this is one of the current situations, piriformis that we know, and then the era of trochanteric entries. What is the trochanteric entry? What is the piriformis entry? Piriformis entry, it's come through the piriformis fossa. And what is the idea of this? Because it's simply in line with the medulla. So you get the nail straight forward into the medulla. Advantage is reduce the risk of iatrogenic fracture comminution. Again, it does not affect the fracture reduction. It does not put the femur into varus alignment. But again, it's a bit difficult in your first surgeries to find out the perfect spot and to start put the owl in the perfect spot. So a bit difficult, especially in OPs. And again, the piriformis fossa is not forgiving in the lateral view. So if in the lateral view, if you get it anterior a bit or posterior a bit, you can just blow this area. So it's not forgiving. That's why we got the greater trochanteric entry. And again, what is the definition? The definition of trochanteric entry is an entry that is a bit lateral to the medulla. It should not be all the time at the tip. Take care about this, because this tip is different. Some people got this tip a bit lateral, some people got this tip a bit medial. So don't look at the tip, but look at the mid-axis of the femur and go just lateral to it. This is the proper trochanteric entry. Again, trochanteric entry, it's easier identification, and because it's cancellous, because it's broad, it's forgiving. So if you get it a bit wrong anterior or posterior in the lateral view, it still will not make a disaster. But again, it's a bit risky if you don't have the reduction well, because it exerts some varus moment in the fracture set if it's proximal especially. So please do your reduction before you put the nail, and this is very crucial for the proximal fractures. So we got these two. What about the evidence? Does it make a difference? This review, 2016, they compared the entry points. Systematic review of 4 studies were included 570 patients. Another one, 2019, again, they compared 2,050 patients in the greater trochanter entry against 450 patients in the piriformis entry, and they looked at everything: operative time, exposure to fluoroscopy, malunion, non-union, abductor weakness, Harris hip score. What did they have in these two reviews? They got similar results. Greater trochanter entry is better. Why is that? Less operative time, less exposure to fluoroscopy, less incidence of abductor weakness, better Harris score, but it does not affect the union. So both will unite in a comparable time, but it's about surgical time, X-ray exposure, incidence of abductor weakness, and better functional outcome. Another point, which more or less is solved, reaming. But let's look at the evidence. Again, this is a review from 2011, compared the reamed versus non-reamed. 7 trials, about 1,000 patients. And this, another one, a more recent one, 2016, another 1,000 patients. What did they get? Again, they got similar outcomes. The reaming is better. Why is that? Lower reoperation rate, lower delayed union rate, lower non-union rate, which means reaming make your fracture unite earlier, and in a better, you have a better chance of union. But there is more blood loss, and we can't do anything about this. But there was no significant difference between implant failure, so both can fail, mortality or adult respiratory system, which is, I have underlined this because it was thought that it may increase the problems with the lung, but again, reaming does not increase this. So you do the reamed nail whenever it's possible, unless it's contraindicated. Of course, it takes some time, which in some patient, critical patient, that you don't have the luxury for putting him asleep for a long time, you should go for unreamed. These are different situations, but standard patient, do reamed nail. Another point about doing the reduction of the fracture femur, open or closed. We tend to see the closed reduction as the standard, but does it make a difference in the outcomes? Let's look at what the people have done. So the literature advocates that closed reduction would keep the hematoma, enhance the union, which give you better outcomes. You can do open reduction logically if you get to shorten the operation time, like in polytrauma patient, or decrease the exposure, like in a pregnant woman. But does it make a difference? This retrospective review in 2020, they got 110 isolated fracture femurs. 65 of them were closed and the rest were open. And surprisingly, there was no statistically significant difference in the healing rates. So both united. Another evidence, 2020, and again, this is a comparative study. And again, the rate of union or time to union did not affected, wasn't affected by the having open or closed reduction. Again, these are studies. They are not meta-analysis or systematic review. I couldn't manage to find due to the time restriction, unfortunately. Sorry for this. But again, we get some growing evidence that open reduction is not a bad thing. In other words, you don't have to do it from the first, but if you try the reduction once and twice and thrice, please give a shortcut, open the fracture site. And from the literature, from the results, it would not affect the chances of union. Okay? Some people would prefer to do it open from the start. We could not disagree with them 100%, but again, just save the patient the scar, the a bit longer rehabilitation for the tissues to heal, and of course the blood loss. So you don't have to be open reduction minded in every case, but just keep an eye on the time. If you fail to do it closed, just open, and it will not affect the outcome. The final thing that we have here to discuss is about the delayed union or non-union. And we got some options: dynamization, nail exchange plate. And these are very valid options and very critical thing to decide. Delayed union, when you have 6 months after the fracture fixation with no union, and non-union that we get more than this without any evidence of union. What can we do at this time? Let's start 15 years ago. This original paper from the International Orthopaedics, they asked this question. They had the 180 closed fracture femur treated with static interlocking nail, and then they got 75 patients dynamized and the rest left static. And here is the surprise. The patients who had a dynamization, they had longer time to unite. So look at here, the patient when they had the dynamization, they united at a longer time, statistically significant in comparison to the patient who did not have any dynamization. That's why simply we might say dynamization is a bad thing. Just keep this at the moment. We will go in depth. Usually dynamization done at 3 months time. So this is collective work over 20 years of experience from the center, and they found that shorter time will be in the non-dynamized fractures. Let's go a bit in depth. What about dynamization or exchange nail? Some people look at this, and it's a bit complex because we got the non-union and the union in the same basket, which is not that good. The non-union is a bit different entirely, but let's look at what they have. They analyzed all the articles, 31 articles that reviewed in this analysis between 1973 till 2015. What did they find? They find that exchange nailing showed higher union rates in comparison to dynamization in terms of non-union. So if you get the patient who is non-united, he is 9 10, 8 months, and you don't have any sign, this is non-united fracture. Do dynamization or exchange nailing? What we got here, that exchange nailing is better. But what about delayed union? The two procedures showed no significant difference. In other terms, if you get a patient with delayed union, you can do both. But taking the cost, the scar, the length of the surgery, let's do the easy thing, which is dynamization. But if the fracture is not united, it will be a waste of time to go for dynamization. I hope it gets clearer by the time. So from this review, dynamization may be an option for a delayed union, but not for a non-union. Non-union would benefit from exchange nailing. Let's dig more inside. This textbook, it's a textbook of effort, the European Surgical Orthopaedics and Traumatology, and in the version of 2014, they got this nice classification of this complex situation. So here we have, if you get hypertrophic fracture pattern, you get a fracture which is delayed union, but it's hypertrophic. It's whether it's stable or not stable, whether it's comminuted or not, wedge fracture, there is a gap, there is whatever, dynamization is unnecessary. Why is that? Because hypertrophic is a problem of mechanics. If you do dynamization, you add more instability. So simply don't do it. Okay? So it is unnecessary. It won't add anything. It might just increase the instability. Second scenario, that is the unstable atrophic pattern. You get atrophic fracture pattern, but in a fracture that is unstable. You got some bit of uncovered by the nail, like a wedge or a butterfly. In this situation, dynamization is contraindicated. Why is that? Because it will increase the instability, and it would definitely don't do anything better to the fracture side. And being atrophic, it means that it needs some biologic boost, either from the patient side, biological problems. We get a very nice lecture about the non-union delivered by Professor Ahmed Thabit in the LRS course. You can look at this lecture in the YouTube channel of the department, and you will have in-depth analysis of the non-union. But if the fracture is atrophic, it's something biologic. Dynamization would not be beneficial, even it's contraindicated. But what if you got a stable atrophic union? Atrophic union in a transverse fracture will fix it. It's stable. Would you do dynamization? That's fine. In this situation, you can do it. So please don't do dynamization for anybody. You have to analyze. You have to understand what is the situation. And you get this summary to make things easier. But again, I'm not done here yet. Just bear with me because we get another option. So what about augmentation plate? Some people advocate just don't do exchange nailing, open the fracture site, put graft, and put plate on the top of the nail. Personally, this is my preferred treatment. Why is that? Let's look at this study. It was done between 2004 to 2015. They had 138 patients who underwent revision surgery, and they have compared two groups: the group who was treated with augmented plate fixation and the group that treated with exchange nailing. We get 70 patients with exchange nailing, 26 patients with augmented, and most of these patients were aseptic atrophic. What was the outcome of this? Let's look at this table, and then we can see that that the union time is shorter in the augmented plate, and that was statistically significant. Operative time shorter, that's significance, and the percentage of the people who have united, it's again better. So in conclusion, augmented plate fixation provide higher union rate, shorter operative time, and a better chance to unite in the first place. So again, take a step backward, and if you would like to attack an union, would you just go for nail exchange or do augmented plate? One crucial thing about thinking in this area is that you look at the X-ray and you see the fracture space between the two fracture ends not united, and then you think that it's empty space. And when you do the reaming, by some magic, this reaming will stay in this space. This never happens. Please, when you open any non-united fracture, just look at it. It's just fibrous tissue. So it's a space that is occupied by some tissue that you have to take it out, put a graft, add some plate to achieve more stability, and then you will be done. All these patients united. So a last bit of evidence in the favor of augmented plate, and this is from the effort open reviews. Very recently, it's 2019, about a year ago, they concluded from this meta-analysis of 48 studies, 3 studies were eligible with a total number of patients, 230 patients. What did they find? They found that augmentation plate is superior to exchange nail. Why is that? Shorter operative time, less blood loss, shorter time to union, and a better chance to unite. So just think about it. Exchange nail is a more hazardous surgery than just adding a plate with a graft to the non-union side. Again, both of them were similar in terms of infection. If anybody asks about opening fracture site having infection, again, they are similar. So we get to conclude this lecture. I hope that I spotted the light over the major controversies, because I'm not able to put everything in half an hour or 40 minutes. So again, for my junior colleagues, please be careful. Patient is more important than the limb. ATLS application, limb saving, number one. Then what about timing? It's 24 hours, okay, but not in the middle of the night. What about positioning? Both accepted. You have to have your own choice and your decision when you become independently operating. Entry, it's the era of trochanteric entry. Again, there is no effect on the union, but it's the era of trochanteric entry in all over the world. What about reaming? Whenever possible, do reaming. Close versus open. Surprisingly, there is no clear evidence. You still can do open, but just don't be minded about overreduction from the start. But keep it in your pocket. If you struggle to do closed reduction after 1 or 2 or 3 trials, you don't have to be a hero to do it closed in 4 hours. You can do this in 1 hour and a half with open, with a small wound, and this will cut many things down. Dynamization, in general, my opinion, don't do it, except the fractures do unite faster without. You may do it after a careful analysis in a stable pattern, atrophic pattern, then you can do it as a thing that would not harm, but it would help. In other situations, it is harmful. What about exchange nailing? It's a good option for non-united fractures. Again, not that good as augmented plate, which is superior. Thank you so much.
Thank you so much, Dr. Ahmed, for this comprehensive talk about all the controversies regarding the fracture femoral shaft. We have some questions. The first question, if bilateral femoral fractures, can you do bilateral intramedullary nailing, which carry a high risk to fix, or you have to fix one nail and the other with fixator? What's your opinion?
It's again about the timing. I think the main thing here, that bilateral fracture femur is a candidate or is a patient that you have to deal with on a damage control orthopedics. This is one of the contraindications for early total care. You are not able to do it in the first 24 hours. So damage control, you will do X-fix for both of them. Afterwards, when the patient is stabilized, you can do one intermediary nail and then do the other in another setting. I didn't have a good reading about doing bilateral femur in the same day, so I'm not able to give an evidence-based answer. But at least you do it by one, and on damage control orthopedics, you can do it on the first 24 hours.
Yeah, the second question, we will postpone it till the talk of our beloved professor, our great professor, Professor Absalam Eid, because it's related to its talk. We have the third question in atrophic non-union. What about sclerosed edge while augmented by plate rather than nail?
Yeah, I thank you, Dr. Muhammad, for asking this question, because that's a very good question. And when you open the fracture ends, you easily can refresh it. So you can just do shingling by small osteotome, very sharp osteotome, do shingling, do petaling, on the outcome and the circumference of the femur on the both sides. Put in the graft, put in the plate. It mostly look the plate. It can be only cortical purchase, but that's fine. You try to get one screw bicortical. This will be hard, but it's not impossible. And then maybe 1 or 2 screws unicortical. This will be perfect. If you do exchange nail, you don't have this opportunity at all.
Yeah, thank you, Dr. Ahmed. Now we will shift to the second presentation, which is the